Thank you. Just stop that. Thank you very much, Mike. Namaste. Good evening, everyone, and thank you very much for the very kind invitation to speak this evening with you. Is that screen sharing okay?
Yes, I'm seeing it. Yep.
Brilliant. So I'd like to spend the next 15 minutes or 20 minutes or so talking about the role of surgery simulation in ophthalmology training. And it does talk a little bit about the stress of surgical education and surgical training. The traditional model of surgical education, the Halstedian model, apprentice model of see one, do one, teach one, takes a very long time and is very stressful for the trainee, often surrounded by a number of other trainees, the theatre nurse, professor, consultant. It's very stressful for the trainer, anyone who's taught surgery, and especially only eye surgery on an awake surgical patient, understands how exceptionally stressful it can be for the trainer. And of course, it's very stressful for the patient who may know that they're being operated on by a trainee. However, there is a huge need to train more eye surgeons globally and to train them efficiently and safely. The most recent estimates from the Global Burden of Disease study group showed that there are 53 million people who are blind globally, and nearly 300 million with moderate and severe visual impairment. And if all the people with blindness and moderate and severe visual impairment from cataract were to be operated on, we would need to perform collectively 130 million cataract operations in the, just to clear that backlog. India has amongst the highest cataract surgical rates globally at over 6,000 cases per million per year. Worldwide, there are 230,000 ophthalmologists. The highest proportion per population is in Greece at 182 ophthalmologists per million population. India has over 17,000 ophthalmologists, 13 per million. And the lowest proportion is in sub-Saharan Africa with just over between 2 and 3 ophthalmologists per million population. For cataract surgical training, well, it's a challenge. And in terms of numbers, in sub-Saharan Africa, the median number of cataract surgeries performed by ophthalmology residents by the end of their second year of training was 0. In mainland China, the median number of cataract surgeries performed by senior trainees at the end of their 3 years of training was also 0. In India, an excellent recent survey showed that the median number of cataract surgeries performed independently during residency was 18 extra caps, 55 manual small incision cataracts, and a median of 1 phaco. However, there's a lot of variability in India, as you can see by the mean and standard deviation, which was higher than the median, but a large standard deviation, and especially for phaco emulsification. An invited recent editorial published in the Indian Journal of Ophthalmology stated that the All India Ophthalmological Society and a few other state ophthalmological societies are doing an excellent job in skills transfer courses where many residents and fellows get exposure to excellent surgical skills transfer courses by experts. And most medical colleges are still focused exclusively on manual small incision cataract surgery and even traditional ECI. In the majority of state medical colleges, there is little to no hands-on training in phaco. And they concluded that wet lab and simulation can be very helpful option for learning the various steps of phaco before, and this is the key part, before proceeding to live hands-on surgical training, and also provided a stress-free environment. And that is very much what I'd like to talk about. So there's a huge need to train more surgeons safely, efficiently and effectively. And is there a role for surgery simulation in ophthalmology training? What simulation is not is a replacement for live surgical education with a dedicated mentor and trainer. It's not a one-size-fits-all solution. It's not a surrogate for motivation, personal motivation, and self-driven participation in one's own surgical education. And it's certainly not merely the presence of a wet lab or the availability of a wet lab. And speaking to the audience this evening as surgeons, if you were given the option of training the surgeon in live surgical situation in theatre tomorrow and Monday, would you prefer to be training the trainee on the left, trying to perform their first manual small incision cataract surgery, not particularly well, or the exact same surgeon on the right after having participated in an intense simulation-based surgical training program for manual small incision cataract surgery? And this is from data from the Olympics trial, which I'll be summarizing in a few minutes, and is exactly the same trainee 4 days later after an intense simulation training course. Simulation skill centers, wet labs, dry labs, they exist in various guises throughout the world, but it's important to say that simulation-based surgical education is not merely the presence of a wet lab or the availability of a dry lab microscope or a skill center. There are numerous simulation models around in addition to animal eyes and cadaver eyes. And here are some of the artificial eyes that are available, as well as computerized simulators. The EyeSeye and the Help Me See simulators are the most popular at the moment. A critical review of simulation-based medical education showed that a number of facets are critical and needed for simulation-based surgical education to work. There needs to be feedback given to the trainee. The trainees need to be able to engage in sustained and deliberate practice. There needs to be a curriculum and curriculum integration. There needs to be outcome and measurement of competency. There has to be fidelity, a transfer to practice, team training, instructor training, and context. And I'd like to add to that list the importance of reflective learning in the process, as well as personal motivation to engage in and want to become a better surgeon. An eminent professor, Roger Kneebone at Imperial College London, stated in his book that simulation offers an environment in which learners can train until they reach specific levels of competency, specified levels of competency. And there are huge benefits to patients. The Royal College of Ophthalmologists National Ophthalmology Database study showed over huge numbers of cataracts that the complication rate, PCR rate, reduced dramatically, up to 40% with the availability of an EyeSeye trainer. The potential of simulation is very wide. Well, it's the initial learning of a particular skill, a particular technique, whether that's glaucoma or cataract surgery. It can enable practicing rare or uncommon complications. It's potentially useful in the return to surgical practice after a period of absence, whether that's maternity or paternity leave or injury or illness or sabbatical or a global pandemic. It's very useful in the maintenance of skills, and it could be useful in assessment as well as team training. For the initial technique skills learning, I'd like to focus on cataract and glaucoma, but emphasize that we are talking about taking a novice cataract surgeon through the stage of advanced beginner to competent. Gaining proficiency and expertise or mastery can only really be gained in a live surgical training setting. So for simulation-based surgical education to work very well, it's helpful to deconstruct a surgical technique, for example, manual small incision cataract surgery, provide instruction in each of the steps, and provide feedback on how the trainees are performing as they engage in sustained deliberate practice of particular steps. Once they've practiced all the particular deconstructed steps, they can perform a full procedure, record it, and then engage in reflective learning as they measure their performance against an outcome assessment. And obviously, fidelity of the simulation itself is very important, as is personal motivation. So here we can see the stages of manual small incision cataract surgery deconstructed, instruction provided and further feedback, sustained deliberate practice. I always use the analogy of the Karate Kid, the wax on, wax off, reflective learning in a digital dry lab, here using STEMI 305 microscopes linked to a digital classroom, and the trainees recording their performance here of a simulation trabeculectomy, which they can then watch back and mark themselves using an outcome assessment and of a ophthalmic simulated surgical competency assessment rubric, which we validated here for M6, and we've also validated and published for surgical trabeculectomy, and others are also available. And again, we're trying to answer the question, as trainers, as surgeons, who would you prefer to take to a live surgical training setting? The trainee on the left or a trainee on the right who's engaged in an intense and successful training program. We tested this and published 2 of the first randomized controlled trials assessing intense simulation-based training. The first was for manual small incision cataract surgery, the Olympics trial, where we randomized 50 resident trainees from East and Central Africa to intervention and control group, and the intervention group came to a dedicated simulation skills center at the University of Cape Town and engaged in a 1-week program of intense simulation training for M6. Control group trainees stayed at home and came for training 1 year later. We recorded 3 surgical procedures, as I previously showed, at baseline, and then the primary outcome measure was their surgical competency at the 3-month period. And this was the results of the Olympics trial. At baseline, out of a possible score on the Sim Oscar of 40, intervention group trainees scored a mean of just over 25%, or 10, nearly 11 out of 40, and that increased after the training to nearly 74%, or 33.7. That competence was maintained over the 1-year period, and then the control trainees who had their training after the 1-year period, they increased as well. Confidence, self-reported confidence scores doubled, and the trainees went on to perform 2.5 times more live surgery in the year after the simulation training. Complication rates, PCR rates, reduced by 72% in the intervention group in the 1 year following the training. Just to back this up, we performed a second completely independent randomized controlled trial following a similar methodology with more senior trainees, and a different group of 51 trainees, again from East Africa, were randomized to the intervention control group, and we published this as the GLASS trial, the glaucoma simulated surgery trial, with the same methodology, all using an intense 4-5-day simulation course. And the results were profound, with a trebling of competence after trabeculectomy simulation training, and that competence was maintained over a 1-year period, and the control group also trebled their competence after their training intervention. Self-reported confidence increased, and the trainees who had undertaken the simulation training went on to perform 20 times more trabeculectomy procedures in the 1 year after training. How have we taken this forward more recently? Is with the Royal College of Ophthalmologists, even a couple of weeks ago, we carried out a very successful digital dry lab, the TRAB lab, and this was our first web lab, where the Royal College of Ophthalmologists Simulation Skills Center had 20 trainees, and simultaneously for the trabeculectomy simulation training day, a simulation unit in Glasgow, East Anglia, and South Devon zoomed in for the day for the lectures and for the discussions, and then they had their simulation equipment and instruments and digital dry lab where they would engage in practice, and then we would all come back together. And I think that this model of remote mentoring and web labs and sharing of surgical education and simulation training will be the way forward, and exceptionally useful nowadays with available technology, and also with travel being curtailed. And this model will benefit us all in further democratizing ophthalmic surgical education as we go forward. I've also recently, predominantly in sub-Saharan Africa, set up a network of digital dry labs and web labs through the London School of Hygiene and Tropical Medicine and the University of Cape Town, currently in Cameroon and Kenya, Rwanda, Tanzania, Togo, and Uganda, and hopefully soon Ethiopia. And I think it's a valuable model for sharing surgical education resources. And we will hopefully gather more data from the utility and the efficacy and the safety of this training model going forwards for cataract and glaucoma surgery, but also potentially for many other surgeries, including ocular plastics, vitreoretinal, and others. Just to finish, just a quick reminder of the fact that something that we inherently all know, but that the Olympics and GLASS trials prove, that merely the availability of a skills lab or a wet lab is not effective in surgical education on its own. All of these facets need to be employed within a simulation surgical education program for it to be effective in impacting the surgical competence, the surgical confidence of trainees, and ultimately patient safety. Once again, a huge thank you for your very kind invitation to speak at this evening's event. It's a real honor and a real pleasure. Thank you very much.
Thank you very much, Will. That's brilliant.